to join this conference, the first newborn association, World Newborn Association, and I hope that the talk will be easier for you and to deliver the information in a good manner. Well, today we'll speak, inshallah, about the updated guidelines of hyperbilirubinemia management according to the Academic of Pediatrics International for 2022 and for the age of more than 35 weeks. Well, I have no any conflicts of interest. First, I would like to go to the baseline of the definitions. The benign neonatal hyperbilirubinemia, that transient and benign normal increase in bilirubin level, which is used to be the neonatal jaundice, and it occurs for 80% of the newborns. Okay, nowadays it's a benign neonatal hyperbilirubinemia. The severity of neonatal hyperbilirubinemia, we have got the expression of the severe hyperbilirubinemia or the level of more than total serum bilirubin 25 milligram per deciliter, and the extreme hyperbilirubinemia for the total serum bilirubin more than 30 milligram per deciliter. Regarding the problem of the hyperbilirubinemia is coming from the bilirubin-induced neurological disorders, which is coming in the acute bilirubin encephalopathy and chronic bilirubin encephalopathy. And the terminology of the connectors is for the chronic bilirubin neuropathy, and this is the bilirubin-induced neurology disorders. The acute form, it consists of the irritability, arching, seizures, and the chronic form is the permanent disabling neurologic condition that characterized by some or all of the following: choreoathetoid cerebral palsy or upward gaze of paresis, animal dysplasia of deciduous teeth, sensory neural hearing loss, or auditory neuropathy, or the synchrony spectrum disorder, and characterizing findings of the brain MRI. There is a score called bilirubin-induced neurologic disorder, and this score points are the mental status assessed from 0 to 3, between normal, sleepy, but arousable, lethargic, and or sensory, socioeconomic, sensory comatose to comatose. This is regarding the mental status, and regarding the muscle tone, also the degree of the hypotonia or hypertonia, and the cry pattern, is it normal or high-pitched or shrill or inconsonable. Then we will give the score to the baby. If it's between 1 to 3, it's consistent with subtle signs of acute bilirubin encephalopathy. If it's between 4 and 6, it's moderate acute bilirubin encephalopathy. And if it's 7 to 9, it's advanced acute bilirubin encephalopathy. Nowadays, the chronic bilirubin encephalopathy is rare, but it's devastating. That's why they went through the updating of the guidelines for the management of the neonatal hyperbilirubinemia. And today we will stress on this management if it's over 35 weeks gestational age. Back to the basic, the pathophysiology of the hyperbilirubinemia in preterm or term infants consists of 4 points. The first is increased bilirubin production coming from the hemolysis of the RBCs, then the decreased bilirubin clearance and conjugation in the liver because of maturity, and the third part is the increased enterohepatic circulation of bilirubin, and lastly in the preterm infant due to the delayed of enteral feeding, which will limit the intestinal flow and bacterial colonization, resulting in further enhancement of the enterohepatic circulation and increase of the indirect unconjugated bilirubin, which is neurotoxic and can pass the blood-brain barrier to induce the chronic bilirubin encephalopathy. This is the picture of this issue. The hemolysis will give the heme, and the heme here, the iron and carbon monoxide. Then we'll go into the unconjugated bilirubin, which is neurotoxic to the brain. Okay, and we would like to prevent this from happening. The unconjugated getting to the liver with the available albumin, it will be conjugated in order to be non-neurotoxic, and will be excreted through the enterohepatic circulation in order to be get rid of it through the stercobilinogen in the stool. Okay, if the enterohepatic circulation will increase, it means that more stress of the bilirubin. So regarding the management guidelines, it's stress as the previous guidelines of 2004 on the prevention and the risk assessment and monitoring and treatment. And it was in 2 tables and 7 figures and 25 recommendations, which is called key action statements. So back to the statistics, this is the first era, okay, from 1956, where there was no guidelines, and the incidence of kernicterus was almost around 16 per 10,000, okay, a year. Then, and the treatment here was with the exchange transfusion. There was no phototherapy. Then after that, the generation of the guidelines, which started on the American Academy of Pediatrics by 1994, and this is the era of the treatment with the phototherapy at the level of 50 milligram per deciliter. Then the last thing, the era of the development of the updated guidelines with the universal bilirubin screening. Here, the bilirubin screening among all the marvelously. We'll pass through the management of hyperbilirubinemia for this age, 35 or more weeks. The station will pass through these steps. The prevention, the guidelines pass through the prevention of hyperbilirubinemia, which is the most important thing to prevent this event to be happen. Then the risk assessment for the hyperbilirubinemia and the neurotoxicity, and monitoring for the hyperbilirubinemia if it's available. Then the treatment of the hyperbilirubinemia, how can we treat and escalate the level of care. Then the post-discharge follow-up, what will we do? And lastly, the hospital policies and procedures. Starting with the prevention, they are concentrating on the preventing hyperbilirubinemia associated with isoimmune hemolytic anemia, hemolytic disease. So each mother should be screened during pregnancy for the RH. And if it's O blood group, then antibody titer should be measured if she received previous anti-RH, or so she is positive or not. And after delivery, for each baby delivered with O mother, okay, the recommendation is to go through the DAT, direct antiglobulin test for the baby, and blood group and RH for the baby, okay? This is as a routine screening. If it's the DAT positive, then we'll go through the issue that we are expecting isoimmune hemolytic anemia on this baby, and we should take care for this baby for the close observation regarding the jaundice. So this is the first key action statement regarding the mother with O blood group. And they make a figure that if for all newborns, we have to do screening for maternal antibody screen. If it's positive, then we'll go to the infant direct antiglobulin test and the blood type as soon as possible. If it's positive, we'll go through these data. The mother infant is positive, or the mother received previously RH immunoglobulin, or mother known to be anti-RH positive before RH immunoglobulin given. Then the infant has hyperbilirubinemia, neurotoxicity risk factor. That's why we'll measure the transcutaneous bilirubin or total serum bilirubin immediately, then every 4 hours for 2 times, then every 12 hours for 3 times. Okay, to guard against the increase of the shooting of the bilirubin. So early detection of the hyperbilirubinemia in these children started from the beginning on the day 1. The other point of the prevention is providing a feeding support. So no dextrose, no oral supplementation with water or shouldn't be provided. Okay, so if we are going with exclusive breastfeeding, it's the best way. Okay, for this, because there was 40 habits regarding giving the babies dextrose or water in order to decrease the hyperprolactinemia. And the key action statement, the recommendation on this guidelines, shouldn't be given this water, dextrose or the water. Then, and the third thing, if we are doing on the neonatal screening, the G6PD assessment, and it became delayed in the day 3 or 4 or 7, that's why we have to suspect that maybe if the baby is the delivered baby is G6PD positive. That's why the mothers of the delivered mother not to supposed to eat anything, fava beans, regarding not to increase the risk of the G6PD hemolysis if it's there. The second point of the guidelines denotes the risk assessment and monitoring for hyperbilirubinemia. Here, identifying the risk factors for hyperbilirubinemia and neurotoxicity. The risk factors for hyperbilirubinemia, this we should go through it from revising the history and the clinical examination of the baby. So we'll go through if the baby is premature, this is an increasing the risk of hyperbilirubinemia. If there is history of hemolytic disease of newborn, early onset jaundice within the first 24 hours is an increasing risk for the significant hyperbilirubinemia. Parent or sibling with who require treatment for neonatal jaundice. Also from the past history, the family history of inherited hemolytic disorder is very important to suspect the significant hyperbilirubinemia. And if the baby delivered with any bruising, cephalhematoma, or internal bleeding, this is suspecting the hemolysis and increasing of bilirubin. If the baby is macrosomic and infant of diabetic, Down syndromes also have got a specific concern regarding these guidelines. And lastly, the exclusive breastfeeding, which may cause or mimic the breastfeeding jaundice. The most important thing is the other risk factors, which is for the neurotoxicity. And these are the 5 risk factors for the neurotoxicity, which are the gestational age, if he's preterm, less than 38 weeks, so it's high susceptibility to that the neurotoxic bilirubin, the unconjugated, will cross the blood-brain barrier and may cause this chronic bilirubin encephalopathy. And the other factor is if the albumin is less than 3 grams per deciliter. The third one, if there is a isoimmune hemolytic disease, okay, positive DAT or G6PD positive or any other hemolytic condition. And if there is sepsis, and the thing that added to this guidelines, that the significant clinical instability in the previous 24 hours. So here, the judgment among the doctor is very important, that there is sepsis clinically by signs and symptoms, and the stability, clinical stability during the previous 24 hours. Here, the albumin, we are assessing the albumin. If the baby is a healthy term or healthy preterm, it's not a matter, no problem if you didn't do the albumin, okay? But on the other occasions, if he's not healthy, we have to do the albumin in order to assess the bilirubin-albumin ratio, which is may be needed in cases of escalation of a care. Also, the DAT may be negative in cases of alloimmune hemolytic disease, that's cases of ABO incompatibility. So the DAT should be done, as we mentioned. If it's positive, we are going with the isoimmune hemolytic anemia. If it's negative, still we can think about the other hemolytic disease of newborn, which is the ABO incompatibility. Well, regarding the second point of the risk assessment, monitoring for hyperbilirubinemia. How we are monitoring? Now it's general screening for all newborns by the visual assessment, okay, is starting from the first day. From 12 hours of age, we have to visually assess. Then, if we notice that there is jaundice, we will go through the transcutaneous bilirubin, okay? Here, the key action statement also use bilirubin as total serum bilirubin is the definitive test to guide phototherapy and escalation of care. Okay, but initially we'll go with the visual assessment. Secondary, we will go through the transcutaneous bilirubin, and for the definitive test is the total serum bilirubin. Transcutaneous bilirubin, the area here, we can use it and depend on it, except for if the threshold is 3 milligram per deciliter less than the threshold for the phototherapy, okay, then we have to do the total serum bilirubin. Or if it gives us the reading of 15 milligram per deciliter, then we will go to total serum bilirubin. Okay. Well, and after the phototherapy, the transcutaneous bilirubin, we can't judge or depend on it for the 24 hours. After finishing 24 hours from stoppage of the phototherapy, we can depend on the transcutaneous bilirubin. Regarding the neonatal screening, guidance for follow-up of newborns undergoing bilirubin screening during birth. So here we are starting screening the bilirubin by age of usually by 24 or 48 hours before discharge if there's jaundice, and we will plot it according to our specific total serum bilirubin threshold for phototherapy based upon the newborn, gestational age, and postnatal age, and risk factors that we mentioned for neurotoxicity. If screening was performed with total serum bilirubin, we mentioned that below 3 from the threshold or 15, we have to go to total serum bilirubin. And total serum bilirubin above the phototherapy threshold, we will start the treatment. Okay. Regarding evaluating elevated direct reacting conjugation bilirubin concentration, for breastfed infant, they may prolong the jaundice till the age of 4 weeks because of breastfeeding jaundice, or in the formula feed babies to age of 2 weeks, and or other causes such as hypothyroidism, and we have to suspect that and to dig for the causes. If so that's why we will request for the elevated direct bilirubin. Regarding the treatment of the hyperbilirubinemia, providing phototherapy, which is indicated here, the intensive phototherapy, and it will be according to the curves of the thresholds for starting phototherapy, then escalation of the care, then exchange according to the level, our specific nomogram according to the age of the babies. Here, the phototherapy threshold for the here among from 0 hour till the 336 hours. So it's increased over the 14 days, okay, to assess, and the levels of the bilirubin in milligram per deciliter, and we'll assess for the patients of the phototherapy threshold for the age of 35, 36, 37, and 38 weeks. This is the phototherapy, okay, with the wavelength of the adequate is 474, and between the 460 to 490, with the blue LED light is the most favorable upon the halogenated or fluorescent lamps. A new terminology of the home-led based phototherapy invented on this guidelines. Regarding the home-led phototherapy, we can allow the home-led phototherapy for the patients if the threshold of the phototherapy is below 2 milligram per deciliter for this preterm infant. If his gestational age more than 38 weeks, this is the condition that we can allow for the home-led phototherapy, and the age is more than 48 hours, and he's clinically well with adequate feeding, no any hyperbilirubinemia neurotoxicity risk factors which mentioned, and no previous phototherapy, and total serum bilirubin no more than 1 milligram above the phototherapy treatment threshold. If it's more than the phototherapy treatment threshold, then we will call this baby in order to receive this phototherapy in the hospital. And the lead-based phototherapy is available at home already. then the total serum bilirubin could be measured daily. If we are sure of this condition, then we will allow the home-led phototherapy. Regarding the prolonged treatment of hyperbilirubinemia, monitoring infants receiving phototherapy following by the total serum bilirubin every 12 or 24 hours according to the cause of this hyperbilirubinemia. And here, regarding measure of the lab investigation that should be done during the phototherapy, if we decide to start the phototherapy, is just the hemoglobin and CBC. Then if we find there is anemia, then we will go through the digging more for the cause of this anemia, okay, including the cause of the hemolytic disease. But no more than the hemoglobin CBC is requested for to detect if there is anemia or not. There is a study regarding the comparison of the end-tidal carbon monoxide corrected, which is added on these guidelines, which is a measurement and compare it with the direct antiglobulin test, the DAT, in the management of neonatal hyperbilirubinemia, which is non-invasive tool. And we find that if the result of the end-tidal carbon monoxide corrected is more than 1.8 ppm, we can expect hemolysis. If it's less than this, it means there is no hemolysis. Okay. So, and the conclusion of this study that end-tidal carbon monoxide corrected is more accurately determinant of hemolysis in the newborn, and its use can lead to less phototherapy. Phototherapy is a method of treatment, and it has got side effects, minimal side effects regarding the development of leukemia, which is non-significant according to the statistics, and development of the epilepsy, which is lower incidence to around 2 to 3 per 10,000 among the 10 years, but still it's a mode of therapy and there should be an indication to start. Well, regarding the discontinuation of the phototherapy, we will discontinue the phototherapy if the total serum bilirubin decreased by at least 2 milligrams per deciliter below the hour-specific threshold at the initiation of the phototherapy. Then we can stop the phototherapy. Follow-up in these guidelines is two parts. First one is the follow-up after the phototherapy, and the other one, the follow-up of the discharged baby without phototherapy. Regarding the follow-up after phototherapy, there's the terminology of the rebound hyperbilirubinemia. That's why we have to repeat the bilirubin within 12 hours, according to the cause, in order to see if it's increasing or stabilized without the phototherapy, in order to plan the management. And it's option if to measure the, as we mentioned, transcutaneous bilirubin after discontinuation of the phototherapy for 24 hours. These are the factors associated with increased risk of the rebound hyperbilirubinemia, which is if it's preterm, if there is a hemolytic disease of newborn, if there's early need for the phototherapy and the jaundice started during the first day. Regarding the escalation of care and providing an exchange transfusion, this is a new concept on these guidelines that we are preparing ourselves for the exchange transfusion of the bilirubin level shoots up 2 milligrams per deciliter, less than the curve of the exchange transfusion. Okay. So here we can find this also. The exchange transfusion threshold, they make two graphs for the phototherapy and for the exchange transfusion. The first one with no neurotoxicity risk factors, the other one with if there is neurotoxicity risk factor. And for the preterms of 35, 6, 37, 38 weeks, and according to the age and hours till age of 2 weeks. Okay, and the level, of course, if there is neurotoxicity risk factors, here is less than the level here. Okay. Right. So this is the escalation. We'll go through the important point. This is regarding the escalation, the exchange transfusion. This is the curve. And post-discharge follow-up. Here, this is very important, the post-discharge follow-up. Beginning at least 12 hours after birth, discharge is being considered difference between The post-discharge follow-up, if the baby is not exposed to phototherapy, then we'll consider the discharge bilirubin level and the expected phototherapy level. Then we'll subtract each other to find the difference between both of them. And if the difference is like this here, between 0.1 to 1.9, so it means that we have to follow up this baby in less than 24 hours. And if the difference is more than 7 milligram between the level of discharge of phototherapy and the expected for the phototherapy, big difference here, 7 milligram, it means we are expecting to see this patient within 3 days. And this is regarding the patients who were not exposed to phototherapy. Hospital policies should be policies and procedures for each baby to be discharged, verbal and written data regarding this condition in order to follow up when he's in need to be seen and where, and everything should be cleared for this. In summary, this is the changes on the guidelines, that the thresholds went up than the previous ones, and also the phases to test the difference between the bilirubin level and phototherapy threshold, no more risk zones as 2004, and includes gestational age and risk factors, gestational age as a risk factor for the newborn toxicity, and the check rebound after stopping, offers how to provide intensive phototherapy and when home phototherapy is an option, and introduce the escalation of care. Lastly, for 1 minute, if I can, there is the bilitool.org. This is for application. We can use it in order to take the decision regarding the child that we have got in order to take what he's in need. So here on your mobile, we have got internet. We can enter either option 1 or 2. If you write the birth date, if you are sampling date, here the age and the sampling time, yani the level of the phototherapy and the timing. Or option 2, which is the easier, that you can write the age of the taking the samples in hours. Then the total bilirubin on this, I make an example here at age of 12 hours and at age of 24 hours, the level was 7, then was 10, and write the gestational age. These are the data that requested. Then you will submit, okay, if there is any neurotoxicity risk factor, you will say yes or no according to the risk factor. Then you will submit in order to get the result. What should be done, the plan of management for this baby regarding the age of sampling. He's reviewing for you. We talk 24 hours and the total bilirubin is 7, and the trending level, if it's more than 0.3 milligram per deciliter per hour on the first day, so it's harm. And after the first day, if it's more than 0.2 milligram per deciliter per hour, it's harmful. And here the trending and the gestational age is reviewing the data that you entered. Then the submit here will give you the result. So you did transcutaneous bilirubin, the level of the to escalate to the total serum bilirubin here at 10.6, and you are 10, and the escalation to prepare for exchange by 16, and the exchange transfusion by 18 milligram per deciliter. Thank you.